Hey y'all, Mr. Forney here. I know we missed a couple class and lecture days. I was going to try and give you all a little supplemental material on the communication and documentation in nursing practice, and here we are. So this is going to be a two-parter. The first part's more focused on communication, and the second part's going to be more on documentation. So try to break them into little bite-sized chunks for you. And this should all support the same material you're getting from ATI and everything else. There shouldn't be anything new in this, but I'm hoping this is an opportunity I can bring my little gems to you. So I hope this is helpful. We have some objectives. We're going to talk about therapeutic communication and communication styles, barriers, and how our effective communication supports accurate documentation. Because believe it or not, we normally think about communication as just being, you're face-to-face with someone or you're on the phone and you're talking to them, but a huge piece of our communication within the medical space is electronic. Our electronic medical record is the most straightforward and everyday piece of our communication we do. So why does it matter? It is critical to be at the center of patient-centered care and safety. If I can't communicate with my patients, how can I know what their goals are? How can I show up for them? How can I keep them safe? We're in a different place in the hospital. The first step is communicating. Hey, you got to hit the call bell. Look, things are a little bit different now. It's time, we have to make some changes. So now, what is communication? We have communication, and we communicate in a lot of different ways. The obvious answer is verbal communication, where we use our words and our tone and our language. There's a big difference between, why are you doing that? What's going on? I want to know the process versus, what the heck are you thinking about? What's going through your head? You think you're communicating the same thing, but really you're coming off very different. So our verbal communication is critical, but so much of our communication happens in other means. There's body language. How do you stand? How do you present yourself? Do you face towards the patient? Do you have a closed posture where you're closed off and not looking receptive, or are you opened up, kind of have your hands open and ready to actually receive somebody? Our emotions are part of communication as well. How do you show up for people? Are you warm and non-judgmental, or are you coming in kind of in a storm that day? Maybe you're having problems at home and they're carrying over into your work. And then we also have communication through our technology, like I talked about, through different monitors of the patients. That's a kind of communication, so you can real-time see their status. Our phones, so we can communicate with providers and other team members. And then the EHR, that's electronic health record. That's something like Epic, which we'll talk about a little more later too. So we have a lot of different kinds of communication. We have a foundation model. This is kind of an old school model, but it's all these pieces are accurate. It's one of the first communication models that was made. It was originally designed for telephone communication, and it helps lay the groundwork for how we communicate in healthcare. In this, we have 6 key concepts, and these are good testable items too, by the way. Every piece of communication has a sender. That is someone who has something they want to say. There is an encoder. That's how we turn our thought into action. That could even be like turning it into words, right? Your mouth, the part of your brain that goes between your thought and your words, can be your encoder. There's a channel. That's where the information gets across. If we're talking face-to-face, that would be just across the airwaves, the sound that comes from my voice over to you. As we're talking through this lecture, the channel is actually over the video. So I'm talking to a video and you're going to receive it. So that's our channel here. YouTube here is kind of our channel. There is a decoder. That's you on the other side taking this information in. That's your ears processing it and going through the different parts of your brain that turn these sounds into actual words. And there is a receiver. That's the actual message you take out of this. And then there's also noise. There's all this background going on, all these distractions to our communication. So these are all important factors to consider. If you think about this setting for one, the sender is me, the encoder is the stuff between my thoughts and my words, the channel is YouTube, the decoder is the stuff between your screen and your speakers and your ears and that part of your brain that takes ideas. The receiver is where that idea is actually set up shop inside of you. And then the noise is maybe your kids are running around in the background. If they're off school today, like I am, it's Tuesday for me now, and my kid's over at the house. I've let her, she's out of my zone so I can actually concentrate a little bit. But there's noise in the background. Now, think about with a patient, if they have a hearing difficulty, then we have an issue with our decoder and we have to adjust with that because it's not going to work quite so intuitively. So if we think practically about these elements, we can actually enhance our communication. There is a Schramm's model as well. This builds on that foundation. And here, communication is more circular. I say something to you, you decode it, you interpret it, then you re-encode what you want to say and turn your stuff into words and bring it back to me. So this communication is a whole loop where it starts with me, you say your piece, I say my piece, we go back and forth. This is where you get to a real conversation, actually. There's also a SMCR model developed in 1960, so it's still pretty old. And it looks at each component in detail. We have the sender, that's the person giving the message, and the factors affecting that are things like your communication skills. That can even be, are you proficient at the language that the person you're trying to talk to talks about? We do not always deal with English speakers, and not all of us in this class are English speakers natively. It's a second language. So can we get our ideas into actual words that make sense? Then our attitudes we bring to the table. Are we going to present it in a way that someone's going to listen to us, or are they just going to feel like they're lectured? Or maybe, I know I get kind of wordy, and I'm sure sometimes I'll start talking all these long words and people will stop paying attention to me. In our culture, there's a lot of pieces in the sender. Pay attention to how you're presenting yourself. Next is the message itself. This is what we want to get across to somebody. How have we set it up? How have we structured it? How have we coded it? This could even be, if I want to talk about heart failure, it's one thing if I talk about heart failure to a cardiologist versus if I talk about heart failure to someone who dropped out of high school in 9th grade and really has no idea about health literacy. That's got to be a very different message for those two audiences. There's the channel, and do everything you can to pick the right channel. Like if you have devastating news to give someone, they just got a bad response back from one of their scans and things are not going the way they want in treatment. Would you want to get that over a portal message? Or would you want to come into the office and talk about it face-to-face with someone? Versus, if you're rescheduling an appointment, maybe a portal message is going to be better. That way somebody doesn't have to drop what they're doing and respond right away. And Lord help you if you miss the call from the doctor's office. They're very hard to get back a hold of. So think about the channel that you're facing. I like how it touches on smelling and tasting. You're not feeding information, but think how those factors could work, especially in the hospital environment, as more distractors and noise. If they've just changed somebody and left a stinky brief in the trash can and the room smells like toilet, then you're going to be distracted. Your patient's going to be distracted and probably not going to be able to hear you. And then finally, there's the receiver. Do they have communication skills to take this? Are they English first speakers? Are they health literate at all? Are they interested in even learning this information? What knowledge, background knowledge do they have to have? This is all part of your assessment. And it comes very naturally, but you have to start with practice. And if we start with intentionality, we can actually get somewhere. But you have to think about it on purpose. So every communication, to break all of these models down, every communication has someone making the message, every communication has someone who's receiving the message, and every communication has the actual message that's coming across. So with these videos, who knows, maybe I don't have a receiver, but I think some of y'all will tune into my little video. But it may not, but that's my intention. Y'all are my intended receiver, so I'm setting it up for nursing students. There's other information, feedback. What do I hear back from you guys? If you guys come to me with questions, I'll actually know that you watched it and had some questions about it. What channel are we going across? What's the context? What's the environment? Is the environment you're in noisy and difficult to talk through or impersonal? Are you in a large triage bay in an emergency department, or are you in a private room in a hospital, or are you in a nursing home, or are you in a clinic? Is that awful floor sweeping machine doing circles around the unit right now and it's so loud you can't hear yourself think? things to think about. Now, closing the loop. This is getting into how do you know what you said was actually communicated? So I could say all I want to, but if you didn't receive it and you didn't understand it, then communication did not really effectively happen. So in the classroom, this is easier. I can see your faces when they get a little confused, and y'all can raise your hand and ask questions. Over this, it's up to you all to reach out to me, but this feedback helps me understand that you understood what I said. So when we're talking with our patients, we want to make sure they understood our messages. When we're talking with our providers, we need to make sure we understood their orders, and we need to make sure they understood our assessments and the information we're bringing to the table. So there's kind of a back and forth that has to happen here. That allows the sender and receiver to both make sure that they understood versus just shouting something into the void and hoping somebody got the right idea. That way you'll end up hurting somebody. So this is important for patient safety. This is my example I've shared with some of you all about when I put way too much nitroglycerin on a patient and dropped her blood pressure out. She had just had a mastectomy, or a breast reconstruction after a mastectomy, and you were supposed to put the nitroglycerin on a very specific place to help draw blood flow out. I called for confirmation because I wasn't clear on the order, and I got one message from the resident, but it turned out that was the wrong message. So this feedback didn't happen the way it was supposed to, and I hurt that patient. I did actually hurt that patient. We were able to recover it and get things back to be okay, but that was a time I harmed a patient because the communication didn't work. So this closing the loop can be verbal or nonverbal. I caution you all in healthcare when lives are on the balance, be verbal, be direct. If someone says that I'm ordering 40 milligrams of Lasix IV stat, you repeat back, 40 milligrams of Lasix IV stat. Don't just say, okay, I got it. Because that way you can make sure if you miss something in there, they have an opportunity to correct you, and you're not going to go make a medication error and probably hurt somebody. So without this feedback, it's easy to see communication is incomplete. And this feedback idea goes so far as, on a basic level, maybe it's your patients nodding their head. But how do you know when they're just nodding their head if they're not nodding their head because they're sick of listening to you and didn't get anything, or if they've actually received that information? So one thing you can do is assess their understanding. Like, I like this little point. Can you tell me in your own words how you'll take this medication at home? That is a good way to make sure someone's going to leave and actually do the therapies you're trying to teach them about. Now, verbal versus nonverbal communication. 2 channels, 1 message. That's 2 different ways information is getting across. Even if you're trying to say the one thing, it's important to try and stay consistent with this. So the verbal communication, the words are important, your clarity is important. Don't beat around the bush and use a bunch of euphemisms. If you're calling because somebody's loved one has died, don't say, well, they've passed over the Rainbow Bridge. What the heck does that mean? You just be direct. I'm sorry to call you, but your loved one has died. Be very clear. Don't leave any room for interpretation. Now, the nonverbal part of this comes into body language. Are you actually going to present yourself as someone who's open, who's interested in engaging in this conversation and being a part of this relationship? Or are you going to be closed off? Make a normal amount of eye contact. You don't want to stare somebody down, but at least in our culture, there's some eye contact. We come to the eyes, we break away, we come back to the eyes at a regular pace. If you think about it too much, you're going to screw it up. But if you don't think about it, you'll probably be better. Just be mindful that you're not just staring off at the wall into space and you're not just staring somebody down. Touch can be very powerful, especially if you're giving really, bad news or uncomfortable news. Sometimes coming over and just putting a gentle arm on somebody, hey, are you okay? I'm here for you, can be huge. So you have to be careful when the verbal and nonverbal communication don't match. Trust the nonverbal communication. That's more of what your heart is trying to say. So for you, just be mindful of your communication, but when you're talking to a patient or someone else, they may be nodding along, but you notice they're getting more closed off and shaking their head. Okay, yeah, I got it. Do you think they really got it? It's important to pay attention to this kind of stuff. Now, how do nurses communicate? We've already talked about verbal and nonverbal. These are pretty clear opportunities. We are there in person with people. We touch people, we work with them, we actively listen when we're listening therapeutically. But we have other communications we have to do as part of our professionalism. So we have our electronic communication. This is electronic health records. That's where you document things like your ADLs and your tasks you've done, your medications you've administered, your assessments you've completed. That's how we chart that. When we need to communicate with providers or other team members, anymore we've moved to secure messaging. It's like a text message on the little phones you get, and it's very convenient actually. It used to be you had to find their pager number and send off a page and wait for them to call you back, and it was the whole thing. But now I just send them a text, and I can tell when they've seen it, and I can see their response. Then I can go back and review their response later if I forgot exactly what they said, and I can confirm back and forth over there, and it's very convenient. We also have telehealth. So in some of your settings, you may end up being a triage nurse, taking phone calls and giving patients direction. That's just another place you want to get as much information as you can. So you want to be open and non-judgmental and caring through that. And when you cut out the body language piece, it becomes even more important to be mindful about how you're coming across over the phone. And then our written communication, we have to document, and some facilities will still use written communication. You're often communicating your handoff materials in a written manner. You're also usually preparing patient education in a written form. It needs a verbal component and a nonverbal component, but they also if they need to be able to do something at home, they need some papers that they can follow along with after the fact. I always like to go through and highlight the important parts and write little notes on there as well. So these are 4 methods of communication that are really, because we're at the center of the healthcare team, they're all essential for us to do a good job. Now, different approaches. We want to be assertive communicators where we're honest and clear, we respect each other's rights, we listen to our patients, but we also tell them directly what's going on without coming off like mean or judgmental or something. But to do that, it's helpful to be mindful of some of this other stuff. Passive communicators don't say anything, might just agree, avoiding conflict. You're going to miss needs that way. Versus aggressive communication, you got to do this right now. That's my way or the highway. Now the other person doesn't have a say in it anymore. And then passive aggressive appears passive on the surface, but is actually somebody who's worked up and unhappy about something. I think y'all have all had people deal with you passively aggressively, and it's not pleasant. Try not to be that person. So we always want to shoot for assertive communication. I promise you, we're all people. We are not always going to get this right, but if we can bounce back from that and rebuild trust and have a healthy relationship with our patients, we'll do a lot better at our job. And our jobs will actually get easier the more our patients trust us, which is a cool kind of counterintuitive thing, but it's a cool way that it works. Now, what all can affect this? There are client factors. Do you think anybody in the hospital is not stressed? I got news for you. They are all stressed out. When I'm stressed out, I can't even follow the nurse to the right room, I find. So stress, anxiety, maybe they're depressed. And if you've ever been depressed, it's hard to process information. Maybe they're afraid. Boy, denial is a heck of a thing. People will only hear what they want to hear sometimes at the expense of getting valid and true information. They'll latch on to the one thing that doesn't really paint the whole picture, but this thing is good, so this other thing that's bad, I won't even pay attention to that. Physiological. We have treatments that we do that will put people out of their right minds. So they could have pain. That's going to affect how they receive things. They could be on medications that make them loopy. When you think about something very formal like a written consent, they won't let you sign a consent if you're under the influence of opioids or narcotics or like any mind-altering drugs. Cognitive status, your demented patient, communication is going to be very different from someone who's competent. But then even things like age, you're going to talk differently to a 5-year-old than you are to a 25-year-old. Our cultural differences, languages we touched on earlier. If you're not a native English speaker, you can get by with, I just need some water or I have pain here without an interpreter. But if you get anything heavier than that, you really need an interpreter to do it justice. And people may not have the same health beliefs. So what is accurate for your training may not carry over to what someone from somewhere else does. They also may communicate differently. Different places have different eye contact standards. Now, the interesting thing about that, being in Charlotte, what do we have? Actually, right on the other side of town is an international airport. So we have our own diverse population in Charlotte in general, but then we can also get people coming that are just stopping over here on their way to somewhere very far away. I had a patient who had major issues. I think he was actually cirrhosis and ended up having a big issues with that. And he was a French speaker. He was flying from somewhere French speaking, maybe Haiti or one of the islands, back to a French speaking country in Africa. He didn't know any English. His phone wasn't even set up to work in America. Nothing. So there was a huge language barrier there, and we had to find an interpreter and figure out, and it was really a lot of chasing things down to do that patient justice. We were able to, but it was a challenge. Now, nurse factors. Your own stress will come across with this. If you're stressed out, at least with me, it shows, and then people don't want to deal with me, and if you don't want to deal with me, you're not going to listen to me. We also approach everybody with our own biases and assumptions. That is something we need to work diligently to check at the door. For example, I'm Catholic, right? And the Catholic Church has beliefs about a lot of different healthcare practices that we encounter in the real world sometimes. I have a friend who was born in a Catholic hospital. Her mother was a single mother, and her experience from that was that the nuns working there were very judgmental towards her. And so she's left with a skewed view of how healthcare works and how, the church itself works. And, it's nice that it's important for us to have our own beliefs, but not when they affect our patient care. So be mindful of your biases and your assumptions when you go in. I always like to clarify relationships too. So is this your spouse, or, what's this person's relation? Just be matter of fact. Who is this person to you, this other person in the room, and is it okay if I talk about your health care with them around? We also have workload and time pressures. We might feel like we're in a rush to get through something when somebody really needs just a little more time to understand something. Then environmental factors, that's something like, what time of day is it? Are we in a private setting? Are we in that triage bay where there's like 20 other people? Or are we in a private room? Depending on your conversation, you might need to change your environment. Bring someone aside, talk to them politely and respectfully. We need to be mindful of the noise. Hospitals are loud. There's overhead pages, there's the floor cleaner, there's people doing all kinds of things. Who knows what? So just pay attention to all this stuff. You'll be okay. There is an OARS technique. This is a therapeutic communication approach. Start with open-ended questions. There's a time for yes or no questions, matter-of-fact kind of stuff. But generally, you're going to get more information if you open the door. Now, you have to be a little careful. Hey, what brought you in today? I don't really need to hear about your surgery from 20 years ago, but I do want things that are pointed to this encounter. And you'll get better at parsing that out as you practice. But if you leave it open-ended, tell me what brought you in here. Describe your pain for me. And you can prompt a little bit, but that leaves the door open for them to tell their story. And your patient is the very best source of their own experience. Affirmations. This is a helpful way to communicate with your teammates too. You've done a great job at this. You're doing really well at this. Here's where I think you could use improvement, but keep doing this really well. I really like a sandwich method. So when I'm talking to you all, if I have to give you some kind of criticism or critique, I try and start with something you've done really good, and then I'll put where I think you could improve, but then I follow it with another good thing. So you don't just think, Mr. Forney's pointing out your flaws all day. And then reflective listening. This shows the person you're talking to that you actually heard them and it made sense to you. It sounds like you're concerned about this. You're not repeating back exactly what they said, but you're kind of paraphrasing it for them. And then you summarize the whole conversation at the end. So far you've told me this, so that they know that you've heard them and they matter to you. They are not just a box to be checked. That helps them come to the table as your patients, and it helps you understand what's going on better so you can actually do a good job for them. Now, what obstacles do we have? Language issues. We've talked about language issues a little bit. Medical jargon is a big one. If you take the Mr. Forney method, I got to break down all these medical concepts down to kind of bonehead level so that I can understand it. And if I can break it down to bonehead level, then I can teach it to somebody else much more effectively. So that's actually a good way to manage that. Cultural diversities, eye contact, we've talked about. Speech or hearing impairments. What do y'all think is the best way to talk to someone with a speech or hearing impairment? The very best thing you can do is ask them what normally works for them. Do they use a communication board, or maybe they're just a little hard of hearing, in which case they can compensate a lot if you direct your face at them so they can read your lips and put those pieces together. Our brains are amazing. We're made to be communicating creatures. That's part of our DNA and our just structure as humans. So if we can empower them to understand us better just by a little change in our body language, that can go a long way. And then you could see developmental or cognitive disorders. Just depends, case by case. Sometimes your patient will be, they're typically your best source of information, but you might have to work with caregivers or around them. Mindful of medication effects, sedation, confusion, effects of recreational drugs. This sounds like an issue for the emergency department more than anywhere else. Physical or emotional distress, environmental factors. So the takeaway from this is there's not a one-size-fits-all answer. Think about what you have to say. Think about if you're in the right environment. Think about how you might need to compose yourself and say this in a particular way. If you need to find a special interpreter for certain things, it's an extra step, but that may be very important for this patient. And if you need to come in with more written materials to support it, maybe someone has to get this information right now, but you don't have a lot of access to them. You give the highlights verbally, but then make sure they go home with it in hand. I remember I went in for a procedure and they put me under anesthesia for it, and they wheeled me out and put me in the car before I was really in my right mind yet. So they told me some things and I don't really remember any of them. Thank goodness they gave me a handout and they followed up. Somebody actually called me the next day to make sure the communication happened and I got the messages I needed out of it. So be mindful of that. And there's a lot of ways to go about this. As long as you're thinking about your patient and how you're actually going to meet them, I think you're going to do okay. Now, we're connecting over from communication to documentation. We have to document when we have effective communication. So documentation is a means of communication across healthcare professionals. It shows what was said, what was seen, what was done, provides continuity. If you show up and you're not sure something happened on the last shift, you go check the chart. If it's not in the chart, it didn't happen. So if there's a question, did this 6 o'clock antibiotic get hung? I don't see the bag in there. Let me check the chart and just see if they ran it early and took it down or something. Maybe it got forgotten at handoff. This documentation will show you if it happened or not. And it is not only an ethical responsibility, but you're legally required to do it. And I want y'all to get this in your head. If you did not document it, it was not done. This goes for everything. This is anything from your specific tasks and medications over to your education. Did you actually teach your patient something? You write it down. And even if they didn't receive the information or they're being, they're having a hard time with it. I think about my patient who was silently aspirating and he was just not interested in receiving and had his own ideas about it. And I kept reinforcing that, look, every time you eat, it's going down into your lungs. Here's the video that shows that, frequent re-education. And he couldn't get it through his head, but boy, I sure covered my bases and I did it every way I knew how to do it. And I let the doctor know too. So cover your bases at least. You do your best. You can't get it all right. So nursing documentation should paint a picture of the patient's current condition, paint a picture of the care you provided. Did they get their bath? Did they get their medicines? Did they get their dressing changes? It should show how they responded to the things you did. So if you gave a pain pill, you'd go back later and check if their pain changed, if it got better. Then any ongoing needs they have. That lets everybody see in the same place, and it also serves as a legal backup for your communication. So critical functions of documentation, continuity of care, tracking patient progress in response to treatment over days or weeks sometimes. It supports clinical decision making. So the doctors take this information and know they don't read every single line item of your assessment. But if they want to see how much somebody has had to drink, they're going to go and look at your I's and O's. If they want to see how someone's eating, maybe the dietitian comes in, they're going to look and see where that's documented. If they want to see if someone's been confused or alert throughout the day or throughout several days, that's where they're going to look, is the documentation. On the legal side, your documentation protects you. It shows that you did what you were supposed to do on the time frame you were supposed to do it. And we're going to talk a little bit more about that in the next presentation. And it can be evidence if you ever get hung up in malpractice. Now, it is also useful for billing and reimbursement. This is an unfortunate reality of our healthcare system. It's all based on money, and we don't get reimbursed if we don't document care we did. It also helps us stay compliant with the different accrediting organizations. And the cool part of documentation, and when you get into informatics and some of the clinical specialists will go into finding data, pulling data out of the interventions you made to determine new care and changes in nursing practice, which is really neat. So to conclude this first video, communication is the foundation of safe, effective nursing care. It's as simple as that. We are communicators. That is a huge, non-negotiable part of our job. There are different models and modes. They follow along very closely. There's someone making a message and sending it. There's someone hearing it. And there's jumbles in between and lots of room for confusion. But these barriers can be overcome, and you can get there. So in the next one, we're going to talk specific documentation formats, electronic health records, best practices, and standards. But there's your first video, you guys. Not so bad. You guys can do it. I'll see you soon.